Well, thank you for the invitation. It's quite an honor to be able to speak after Marcus before Jürgen. It's quite a challenge too, but I will do my best. I was asked to talk about idiopathic spinal cord herniation with or without SIH, so I'll do my best. I have nothing to disclose besides a taste for very loud music. And I will start with some cases. The first case is a male of 59 years with an antiphospholipid syndrome, otherwise healthy, and he had slowly evolving complaints in 2 years. Were mostly sensory disturbances of the left leg and the lower abdomen. He had trouble discriminating warm and cold when taking showers, and he had some pain inside the left leg and painful sensations on the left side of the trunk about 10 centimeters below the nipples. And he also noticed mild difficulty in walking and some stiffness of his legs when he got out of bed in the morning. On examination, he had diminished sensation for touch and pain in the left leg and the trunk up to T10. He had inability to discriminate warm and cold in the left leg. He had no right-sided sensory disturbances, and gnostic sensation was intact, and he had some subtle pyramidal signs, otherwise normal. So he had basically a Brown-Séquard syndrome-like neurological examination. An MRI was made, and it clearly showed a displaced spinal cord, FT667, but that's actually the apex of the kyphosis also. But the axial MRI showed clear anterior spinal cord herniation. It's operated under general anesthesia and monitoring. And we did a targeted laminectomy, opened the dura, mobilized the cord, reduced the herniated spinal cord from the defect, and I closed the dura defect with muscle and fibrin glue. Tried to do other things, but that did not work well with the monitoring, and the DOAs diminished, so I had to try to do this, and it worked quite well. He improved a little, but he was still troubled with the persisting painful zone on the left side of the trunk. But the post-operative MRI looked nice with not herniation anymore, and just a small focus of myelopathy. Anterior spinal cord herniation is actually herniating spinal cord through an anterior dural defect, and that leads to strangulation and tethering of the spinal cord. It's almost exclusively seen in the thoracic spine, although I was able to find a report of dorsal spinal cord herniation. It is the thoracic spine because of the kyphosis and the ventral position of the cord there. Most people are between 30 and 70, and there's some slight female preponderance. And clinical presentation is mostly Brown-Séquard syndrome, like myelopathy or other lower extremity motor sensory defects, but rarely SIH. Actually, it was first described in the 70s as an accidental finding during intradural thoracic disc surgery was at that time common. It's a rare condition. It used to be difficult to diagnose, but not anymore with all the MRI possibilities we have now. But it's important to diagnose because surgical intervention is often useful. Differential diagnosis is mostly posterior intradural arachnoid webs or cysts, and they have often that typical scalpel sign. And it's, as I already said, mostly seen around the apex of the thoracic kyphosis because of the proximity of the cord to the ventral dura. There's a lot to do about what is the cause of the ventral dura defect. Might be congenital, like a dural duplicature, or maybe developmental, in the sense that the sections of the two blades of the dura exist. It can be after surgery or trauma, but probably most common is degenerative disc changes, spurs, causing slit-like defects in the dura, which can cause then cord herniation, but could also be causing ventral CSF leakage and causing SIH. Well, since spontaneous intracranial hypertension is the topic of this conference, I think we can skip this slide. Everybody will be aware of what the symptoms are. And I've been looking for a patient with both SIH and a spinal cord herniation, and Matthijs Brouw was so kind to come up with this patient, was actually a patient of him and Peter van der Top. That patient was seen in Amsterdam, was referred from another hospital. He had some unexplained myelopathic syndrome, probably some kind of mild form of bibrachial atrophy, and there was evidence of anterior epidural fluid collections. He had a history of more than 7 years awkward sensations in his arms, not painful, maybe related to sports. He had in the past an MRI of the cervical spine. He had a small disc protrusion, which was managed conservatively. He started to develop weakness of his arms later on, and that was stable for some years. And then he also developed decreased sensory sense in the left leg, especially warm-cold discrimination was difficult. And he got some hyperpathic sensations in the left leg. No walking difficulties with other complaints. It didn't really interfere with his life. On examination, he was right-handed, had normal cranial nerves, had some right-sided atrophy of the deltoid and the biceps, and also of the right quadriceps, and right-sided weakness, although he complained also about weakness of the left upper arm. And he had maybe some pyramidal signs in the sense that he had normal reflexes on his arms, but brisk reflexes in the legs. And otherwise, he had no abnormalities besides some diminished sensory sense of the left leg. He also had this anterior displaced spinal cord and an herniation, but also epidural anterior fluid collections over a large trajectory. He was operated by Peter van der Top under general anesthesia and monitoring, also a targeted posterior approach, cleavage and resection of the indurated and adherent epidural fat, opening the dura and mobilizing and rotating the cord. And the dural defect was identified, the cord reduced, and he closed the dura with 8-0 sutures and Tegsil. Some pictures to show you. This is the indurated and sticky epidural fat, and he encountered firstly, this is the anterior tear on the right side with the rim from the lateral side. This is the caudal end of the tear. It's quite a large tear. The tentacular ligament was tented with sutures, and then the anterior dura defect was closed with 8-0 prolame sutures. He also improved a little. He had some better power in the leg, otherwise no changes, and the post-op MRI also was nice with resolution of the herniation and of the slacks. Well, intracranial hypertension and spinal cord herniation have a common cause. It's a ventral dura defect in the thoracic spine, However, it's rarely seen together at debut, maybe because both of them, of course, rare. It is mentioned in the literature that it can debut together, but I was not able to find a lot of case reports about that. Probably because of the spinal cord herniation tamponates the defect, and also because the insidious onset of the spinal cord herniation symptoms, which will probably precede and resolve again before the signs and symptoms of spinal cord herniation are noted. Therefore, both rare entities and related, of course, by nature of the underlying pathology, which is an anterior Dural defect. And a combination of both at the same time at presentation is very rare, but maybe improved awareness and even better imaging techniques will lead to more cases in the future. Surgery can often halt deterioration and improve outcome. A correct localizing diagnosis is, of course, important. It can be, the dural defect can be closed with primary stitches, but also with patches or slings that you can put under the spinal cord over the defect. You can also obliterate the defect with dural substitute, muscle fat, Tacil, Tagocil works pretty well also, or combinations of these. And complications are, apart from the usual complications of this type of surgery, recurrence, and especially severe arachnopathy and tethering after a recurrence. Then I have another peculiar case of spinal herniation and intracranial hypotension syndrome that we encountered in Utrecht 2 weeks ago. It was a 25-year-old recovery nurse in our own hospital with Loeys-Dietz syndrome, which has been talked about already by Marcus. And she went to the doctor because of the abdominal complaints, ended up at the gynecology department, and they thought she had an ovarian cyst, and there was a laparoscopic fenestration and biopsy of that cyst. And then she was sent home, and she was admitted a few days later with severe positional headache, muffled hearing, dizziness, nausea. Was seen at the neurology department, where the diagnosis of spontaneous intracranial hypertension was made. And then, of course, we did spinal imaging, and what we actually saw was extensive dural athasia, but also herniating intestine into the spinal canal at the sacrum. And this is a CT scan we made of the sacrum, and you see these very, very strongly enlarged holes of the sacral anterior foramina. So the ovarian cyst that was fenestrated was actually a large cystic herniation of a dural ectasia to the right S2 foramen, and we operated her last week. Did a laparotomy, removed the herniated intestine from the sacrum, and then covered the S2 foramen with artificial dura, Tagocil, Varbing glue, and with a pedicled vertical rectus abdominis muscle flap. And she's doing fine, but she's still having bed rest because we are very anxious to mobilize her and hope that this will help. Thank you.